Good evening and welcome to the next webinar by AMR Declaration Trust, the role of vaccination in tackling antimicrobial resistance. We discuss the role of vaccination in combating antimicrobial resistance. We all know that vaccination is a cornerstone of preventive and public medicine, and it's increasingly recognized as an important tool in tackling the challenge of antimicrobial resistance. AMR Declaration Trust do not charge any registration fee to the attendees. To make this possible, we accepted unrestricted educational grant from Milan and Pfizer. Today, we have eminent panelists. We have Dr. Jacob John. We all know him. He's an eminent virologist. We have got David Heyman from London. He's a very reputed and renowned infectious diseases epidemiologist and former Assistant Director General of World Health Organization. We have Dr. Vidya Krishna, a pediatric infectious disease consultant from Apollo Chennai. And we have Ashwini Taide, an adult infectious disease consultant from Maharashtra. And I'm Dr. Abdul Ghafoor. I'll be moderating the session. Jacob John, sir, how do vaccines contribute directly or indirectly to reducing the challenge of antimicrobial resistance?
Thank you, Abdul Ghafoor and friends. When I started my career in CMC Vellore, I was in charge of the healthcare of about 200 families. Kind of low, I would say today's jargon, BPL, below poverty line. And being a pediatrician, I knew more about children's illnesses. And annually, there were about 5 diarrheal diseases and 3 mostly upper respiratory infection diseases in these children for 5 years, approximately. Newborn is slightly different, but so that was the burden of gastrointestinal and respiratory diseases. So you can imagine what preventing these would do in terms of the illnesses, the number of episodes, and if they were being treated with antibiotics, which we are not, if we were to be given antibiotics, you can imagine how much antibiotic would have been used. Why in tuberculosis, the teaching is try amoxicillin clavulanic acid for some time to see whether the cough and the fever would settle. If not, go for TB diagnosis. I mean, this kind of, we have these kind of problems in our medical healthcare management system. Now, take measles virus. It leads to, in addition to the measles by itself, a lot of secondary gastrointestinal and pulmonary diseases, and that partly secondary infections in the immediate post-measles period. And for about 3 years, these children have immunodeficiency. So they have more number of episodes of such acute respiratory illnesses. So preventing these would reduce the overall antibiotic consumption use, and that would lead to reduced AMR. Simple common sense approach of reducing the over, what do you call treatment without true indication. That is a major contributor to AMR. So along measles, rotavirus vaccines, we have it in a national immunization program for children, what we call the UIP, Universal Immunization Program. So these 2 vaccines, measles, add pertussis to it because it's also respiratory. Measles pertussis vaccines and rotavirus vaccines have remarkably reduced the number of episodes of gastrointestinal and respiratory disease, which people by knee-jerk reaction rush with antibiotics. Back to you, Gafur.
Thank you, sir. Thank you very much for that valuable and insight from a very experienced person. David, you are one of the senior most infectious disease epidemiologists in the world, one of the most experienced. What evidence supports the impact of vaccines on population level antibiotic use and AMR patterns?
Thanks, Abdul. Actually, vaccines are, as Jacob said, very, very important. And I just give you one example. Smallpox was eradicated in 1980, and it's a viral infection. By being eradicated, lives have been saved, illness has been prevented, and the use of antibiotics for secondary infections and septicemia have also been decreased. So part of the stewardship today for antimicrobial resistance is decreasing the use of antibiotics, and certainly the vaccines are doing that. Viral infections, though, as you know, also become resistant to treatment. And therefore, things like influenza vaccines are very important because influenza at times is becoming resistant to other drugs that are available for its use. So the vaccines for viral infections, as Jacob said, prevent the use of antibiotics, and they also prevent the presumptive use of antibiotics, because most times in many countries, including industrialized and lower middle income countries, presumptive treatment is what's used by the clinicians, except in hospital cases, to really treat infections. And finally, I think it's very important to understand that we do need also more bacterial vaccines. And so hopefully they will come along as well. Back to you, Abdul.
And David, again, one question. How can we use the vaccination data in designing AMR surveillance system? Currently, we don't utilize that data when we design the national policies or AMR policies. Is there any correlation between the vaccination data in a region and we can utilize it for designing the AMR policies?
Yes, I think resistance data is useful for many different reasons. And the first one might be to do some cost-benefit analyses of vaccines in order that the government understands how much money they could save if they increase the use of vaccines in areas where they're not being used properly. At the same time, again, repeat your question, the second part.
Because we do have the vaccination data from various regions.
Yeah.
Can we use that data to design the AMR action plans?
Yes, and that's by modeling, by showing what, in effect, the vaccine coverage would have on the use of antibiotics. Think of pertussis, which is bacterial, of course, but there's no antibiotic use for pertussis in most countries because they've been able to get rid of the disease, or at least keep it at a low level through vaccination. Same with measles, as Jacob said. Measles superinfections with bacteria don't occur when measles doesn't occur. So we've just got to convince governments, and one of the ways of doing that is cost-benefit suggestions by modeling.
Thank you, David. Vidya, you are a pediatric infectious disease consultant. Now, of course, vaccination, we all know, play a very important role in the pediatric practice. And how can the pediatric vaccines such as pneumococcal vaccine, Hib, or rotavirus vaccine, in what way they can contribute in reducing the antimicrobial resistance in the pediatric population?
Good evening, everybody, and happy to be sharing the platform with Dr. Jacob John, sir. We have grown up seeing him. So as sir was rightly saying, like pneumonia, respiratory infections, and gastrointestinal infections are the major reasons why healthcare is sought in pediatric population or antibiotics are used in the pediatric population. So definitely use of pneumococcal vaccines and the rotaviral vaccines have helped reduce the disease burden, illness burden due to both gastrointestinal illnesses as well as respiratory illnesses. So directly, I think that has an impact on reducing antibiotic use and antibiotic resistance. And in my own career, I have started, like when I started, Hib vaccine was not in place. So once the Hib vaccine got introduced into the national program, I have hardly seen a case of Haemophilus influenza meningitis in a child. So that is the success of that single vaccine. Actually, we don't even think of covering for Haemophilus influenza, be it a pneumonia or a meningitis, in a completely vaccinated child. So that is a big impact that vaccine has made. Obviously, pneumococcal vaccine, the repertoire is going to keep increasing, and we can talk about what it's going to lead to. But having said that, that vaccine has made a great impact in the reducing the disease burden, and to some extent, AMR in that way. Thank you.
Thank you, Ved. I still good thing you mentioned about the Haemophilus influenza vaccine. I remember when I was in UK, when I was doing my training 2003, 2004, that time, we had one kid with Haemophilus influenza septic arthritis. And that particular kid was not vaccinated, quite unusual. And I did the presentation called The Uninhibited Child. That's importance of vaccination in reducing the prevalence of infection and reducing the antibiotic usage and reducing the antimicrobial resistance rate. Ashwini, you're an adult infectious disease consultant. What's the role of vaccination like pneumococcal vaccine, flu vaccine, and other vaccine in reducing antibiotic usage and reducing AMR in adult population?
Yeah, good evening, everyone. So, like everyone is discussing, vaccination has significant role in cutting down the burden of infection, severity of infection, especially flu, pneumococcal. We know the major overprescription or commonest misuse of antibiotic is basically for respiratory, GI, and urinary infections. Unfortunately, adult vaccination or adult immunization in India is not yet an established concept. Yes, fortunately, after COVID, it has taken a boost and people have started realizing it is important. People have started going for it. But still, we don't have significant amount of population who is vaccinated, especially adult population. But having said that, yes, definitely we have seen the impact in the way that severity of flu has gone down, pneumococcal infections, what we see, that has gone down. And indirectly, the secondary infections, what we see in ICU, because all these elderly land up with severe pneumococcal disease and all land up in ICU. So that burden of secondary infection has also gone down a bit.
Thank you.
Probably
David?
Dr. wanted to.
Yeah. Hello.
John sir wanted to say something.
Sure, sir.
Just an episode. 2009, I was the chairman of the National Technical Advisory Group on Immunization, and we had two vaccines we wanted to introduce in 2008 onwards. Two subcommittees looked at it. One was Hib vaccine, and the subcommittee chaired by M.K. Ban recommended it, and the committee recommended it, and the government was going to roll it out as pentavalent vaccine. A new health secretary came, replacing the old person. That person happened to be an anti-vaxxer. And she vetoed hepatitis B vaccine and Hib vaccine and said this is commercial interest. And so she removed both the secretary of the NTAGI with from the Ministry of Health and the chairman of the NTAGI, myself, and then she appointed new people. They more vehemently recommended Hib and hepatitis B vaccine, and she had to accept the recommendation. And that is how in 2010, Hib vaccine in the form of pentavalent came into India. Just a hiccup that we had, and we still have occasional senior people who are anti-vaccine with anti-vaccine sentiments. Okay, back to you.
Thank you, sir. David, back to you. A lot of data is available on the cost effectiveness and impact of pneumococcal vaccination and other vaccines from various countries. And in what way the vaccination can reduce the AMR, especially from an economic perspective?
Right. Well,
Because it's quite expensive to vaccinate the population.
it's expensive to vaccinate, but it's also expensive to have to use second line antibiotics, which are new ones, which are more costly. And so, all this is down to modeling because it's not possible to get the data at present. But we can model what would happen in various settings if, for example, the pneumococcal organism became resistant to first line antibiotics. How much more will the second line antibiotics cost? And how much is the vaccination program? And I would be willing to bet with the production of vaccines in India and the purchase in India that vaccines every time come out as more favorable than continuing treatment with antibiotics and preventing admission to hospitals, which is extremely expensive and which also causes the additional risk of hospital-related infections in children, in persons who are admitted to hospitals. And those infections are many times resistant as well. So it's a win-win situation with vaccines, but it takes some good epidemiological modeling and various scenarios because of the lack of data to show our policymakers that they need to pay attention to vaccine. And Abdul, this includes also industry, which should be developing more and more vaccines. The antimicrobial resistance agenda is skewed towards new chemical products, new antibiotics, new antivirals, and the real solution, as we all know, is vaccines. So money needs to go there also.
Right, right. Jacob Jones, sir. So what are the major barriers in improving the vaccine uptake, especially in the AMR hotspots?
Will we sell vaccines for AMR prevention? I think it is a little roundabout way. We should be promoting vaccines for its inherent primary value of preventing diseases. It's a spin-off that AMR will be prevented. So we should learn to use vaccines to the maximum effect. And here is the problem. Anything that is called vaccine, we should be careful in promoting it carte blanche. We have to be, we have to use our discretion, judgment, and provide those vaccines that are essential for our own children's benefit, children or adults, as the case may be. Let me say 2-3 things. Typhoid fever, anything that is suspected as typhoid fever is treated with antibiotics. And these days you have drug-resistant MDR typhoid and very good vaccine available, conjugated VI vaccine. How well is that used to prevent typhoid? Countries like Zimbabwe and Pakistan have shown that it's a very good way to reduce their burden of disease of typhoid fever. So that brings me to the issue of the EPI and UIP are vaccine delivery platforms. Okay, we push vaccines and we get even 90% coverage these days. But if you look at as a business model, a systems analysis, there is inputs, processes, output, and monitoring of all three. The output or the outcome of the program is disease reduction. Are we measuring the disease reduction and showing to the public that, see, this vaccine has reduced? No, we are not. We don't have that. We don't have that suprastructure in order to get the accurate data. You said one case of hemolytic influenza meningitis in UK. You can have thousands of them in India, and people will not know about it unless the Hindu or some newspaper comes with it. Then we know there's an outbreak. So we need a disease monitoring platform. And I wrote once a paper, and David Heyman added an editorial. I don't know whether David remembers that, in Indian Journal of Medical Research, about a simple way of disease surveillance based on a postcard system. Anyway, so we need what the developed world calls public health. We use the term public health for public sector healthcare institutions. That's not public health. Public Health England or Public Health Service in the USA, and all developed countries, so-called developed countries, have public health. The undeveloped or developing countries do not have public health. So we need to learn to bring in public health into our medical health management system, in which case we will then see the value of vaccination in reducing disease burden. Second point, the consumption of antimicrobials. 50% is for human beings. 50% is for animal husbandry. Cattle, sheep, and chicken, or whatever. Okay. So the concept of One Health comes in. If you don't have public health for human diseases, how does One Health work? So the big missing elephant in the room is that India, aspiring to be a developing country, does not have public health. So we need to introduce public health. I can add one more thing into this, and this will impinge on your general discussion. The panelists, including David, the biological criteria for eradicating a disease globally is that no non-human reservoir. Typhoid fever has no non-human reservoir. An effective vaccine, primary prevention. Typhoid fever has primary prevention. You need to recognize the disease. Can you diagnose it? Yes, we have good diagnostics. So biological criteria fits typhoid fever very well. Why is there no agenda to eradicate typhoid fever? Because it's a poor country disease. Okay, so from the developed country viewpoint, they will manage introduce typhoid fever by travelers. So what is missing in typhoid eradication? And so that is the best way to prevent AMR and MDR, typhoid fever, etc., etc. We need champions. Every disease eradication program has had champions. So if David can think about it further back in London School, and if you think that typhoid fever is an eradicable disease, then it's well worth the efforts to eradicate typhoid fever globally, that'd be a great step forward in terms of a big AMR problem solved. Back to you.
Thank you, sir. I'll ask that particular question to all the panelists. Sir mentioned public health is a missing elephant in the room in countries like India. We claim we have a public health, but that's not really the public health, the true meaning that countries like UK, USA, or many developed nations have got. Vidya, what is your opinion on that? Especially, sir mentioned about the role of typhoid vaccination in reducing the MDR typhoid. There's data available from Pakistan. I recently read a paper.
Definitely what research, I mean, I am not claiming to be a public health professional. I'm purely a clinical ID person, but I will just say what probably like what looks like a layman thing in public health. But generally, when I talk about advocating vaccine, it's very, very important for me to know what is the exact disease burden. The only problem that I really feel that in India, where public health is really not there, is sometimes we don't have much data. We don't have data and what extent a disease is prevalent in a population. This might be more relevant for other diseases that we will be talking about, like say RSV or something like that, where actually diagnostics, we don't have good diagnostics. We don't have cheap diagnostics. So many times we don't even measure the disease burden. We assume that this disease is prevalent in the population. I think even when pneumococcal vaccination was introduced, I have discussed with Sir only, Dr. Ghafoor himself used to say, do we have pneumococcal disease in India? So why are we advocating this vaccine? I remember having that talk with you, sir. So many of us actually are not aware of what exactly is the disease burden because we really don't have cheap diagnostics. We don't have universal access to diagnostics, and we treat empirically still in this day and age. So if that is a situation when we don't know the disease burden, then you cannot advocate for any particular strategy, preventative strategy. You can't take it forward. So I think public health should start from there for me, where you know what exactly is going on in your community. I know what I should be advocating for.
Right. They rightly said that. We are underdiagnosing many infections because of the unavailability of affordable diagnostics. You rightly said about the pneumococcal burden. Recently, we experienced the same thing about RSV because we test less and less of our patients, including our oncology patients with respiratory infection, because tests are expensive and many of them can't afford. And recently, you remember when we had a low-cost, affordable respiratory diagnostic panel, the number of RSVs we detect has significantly increased over the last few months because test is affordable. In our oncology patients, I started prescribing more and more ribavirin for moderate to severe pneumonia because of RSV. And previously we were underdiagnosing RSV infection. And I used to talk to Vidya, you're a pediatrician, you may be seeing a lot of RSVs. In adult, I see only once in a while. But nowadays I'm seeing more and more RSV because I'm testing all oncology patients with respiratory symptoms. I diagnose and I treat more. And I prevent more transmission of RSV in the hospital setting. Better infection control, better diagnosis, better outcome. Ashwini, what do you think in your experience, adult practice?
So first of all, I like to say something about the typhoid. We know we have good diagnostic available, but that's not been used. The way typhoid is diagnosed in India is still Vidal. If you go to periphery, and it's very few hospital who will use blood culture to diagnose typhoid. So we still have whatever typhoid we are seeing, probably it's just the tip of iceberg, and we have lot more into society. The second apprehension I have about typhoid vaccine is we have almost 40-50% of it as paratyphy. So that is not covered with the vaccine. So enrolling it as a priority vaccine, I really don't know. I had attended one ICMR meeting wherein they were discussing which vaccine should be prioritized to implement as adult vaccine program. And they were just discussing about the disease burden. So typhoid was one of it, but then there are other priorities. Probably we will have to think about those diseases before thinking about typhoid as a disease. Having said that, yes, significant amount of antibiotic misuse is due to typhoid because there are people who are coming up with multiple Vidal positive and they are saying we have chronic typhoid, and that's what happened in adult practice actually. So implementing typhoid vaccine will definitely be a great game changer for enteric fever perspective per se.
David, what do you think about, what is your opinion about introduction of typhoid vaccines for pediatric and adult population in developing world?
You know, I think it's an unknown toll of mortality that comes from typhoid. But the more we learn about it, the more we understand that it's very important. And it's also important in other countries as well. So it would make sense to have some type of a global program that would be targeting possibly the elimination of typhoid. Elimination meaning decreasing it to zero in a place where there is transmission, not necessarily eradication, but decreasing transmission and eventually reaching zero. So I think typhoid is extremely important in all countries. And it's very important that, you know, the one problem, of course, is that animals carry the infection. And so eradication would not be possible, but certainly better control and elimination among human populations is possible. Over.
Vidya, what do you think? Should we introduce? Yes, sir.
Can I say something here?
Yes, sir.
You see, respiratory transmitted infectious diseases are ubiquitous everywhere. Everybody, rich, poor, everybody is at risk. Children, and you know, whichever virus you're talking about. Whereas the fecal oral transmitted, like Shigella or Salmonella, it is not ubiquitous. It's not uniformly. It's not democratically distributed. Some people are at risk, others are not at risk. When I looked at the typhoid epidemiology a long time ago, urban populations are at more risk for typhoid fever than rural populations. It's probably due to water supply, something. Anyway, there are, so adding typhoid vaccine into the universal immunization program does not make sense, very much like Japanese encephalitis vaccine is not in universal immunization. It's given where it is needed. So that is why I'm pushing for getting rid of typhoid fever altogether. And that will require vaccination as part of the intervention. But typhoid fever, eradication of typhoid fever will not be very expensive. Countries will accept the burden of vaccines and vaccinations. So I think all eradication of typhoid fever needs is a champion or more champions to vocalize the fact that typhoid fever is a mess. Paratyphi A vaccine is in the pipeline. So typhoid, paratyphoid, enteric fevers are eradicable. And the reason why we are not venturing into eradication, one reason is the polio, you know, has not, the job is not done. So people have a little bit of allergy to the word eradication right now. We are struggling with measles and rubella eradication and not reaching very much, and achieving very much. But in 2, 3, 4, 5 years, measles and rubella will be eradicated. Do you know that in India, rubella is not detected anywhere? We have a district-wide district virology program for fever and rash, ICMR, and Government of India. Rubella has almost vanished. That's because we use a 2-dose regimen. By 2 years of age, measles rubella vaccine, and 95% coverage is enough for rubella, not quite enough for measles. So that, you know, that is so eradication is not something to be taken ill-advisedly or light-heartedly. However, for typhoid fever and all the antimicrobial problems and the diagnostic, everything, the one answer is eradicate it. It is eradicable. It's a disease of only poor countries and so the rich country people will not champion it. We have to champion the cause for eradication of typhoid fever, and India can lead the way. India makes a good quality conjugated typhoid fever vaccine. They can upscale it to any amount we want. So if we, the four of us, and if David, I do not know his mind, join together for an advocacy of typhoid eradication. Okay, we will think about it later, not immediately, but David, you tell us your view in due course. You take time to think about it, 2 weeks or 1 month, and you email to me whether you will be willing to join a group of champions for typhoid eradication.
I'm ready to join, sir.
No, the four of us
I have
are.
seen people using colistin for culture proven.
Typhoid.
Joining,
David,
joining may
what-
mean, but joining may also mean the need for an animal vaccine as well. And so we need to be thinking of that as we move ahead in addition.
Right. Wasn't it the Pakistan reported carbapenem-resistant salmonella and used colistin?
Can I say something about colistin?
Yes, sir.
It was in 2010 that China reported the plasmid for colistin resistance. By the way, we think we are the users of social media. Bacteria knew social media millions of years ago. And they pass on plasmids and the information, and they watch out, that antimicrobial is coming from there. Okay. So colistin was banned in animal use in China in 2010. Within a year,
2016, sir. They banned 2016. And we banned 2019. China 2016.
Yeah. We decided to abandon it in 2019. Most other countries, no, China did it immediately. But other
Right.
countries joined the bandwagon slowly, and we in 2019. But do we have a mechanism to actually see whether it is being implemented? We don't have. So the One Health approach, the big gap is lack of public health. So we need to champion, although we are in the healthcare endeavor, we need to champion the public health approach, especially for problem like AMR. Okay.
Right, sir. Right.
Thank you.
I remember a few years ago, just before the introduction of pneumococcal vaccine, probably 6-7 years ago, I writing to health ministry, we should give preference for typhoid vaccination. And of course, pneumococcal vaccination is very important, should give preference for typhoid vaccination. Now that we are introducing the pneumococcal vaccine, we need to take measures to introduce typhoid vaccination, because all of us see typhoid every day, culture proven typhoid every day. All physicians in India see typhoid, proper culture proven typhoid, enough and enough. Yes, most of them may not be dying, but the morbidity and the disability adjusted life years is significant for a country like India. And if we introduce typhoid vaccine, should we introduce it in the pediatric population first, or adult population, or both? Vidya, what do you think?
I think we should definitely. I mean, right now, I think the IAP recommends that it should be given from infancy itself. I don't know, but what I see in practice is a lot of adolescents and maybe young adults who come in with typhoid disease. So somewhere the lifestyle, the eating out, the behavior. I mean, I'm practicing properly in a city area. I don't know about what happens in, say, a semi-urban or a rural area, but I understand that the disease is very less in the rural setting. It's more a disease of cities and urban places than in the rural area. Here, I think the concept of eating out and probably that is what drives the disease, more of contaminated food and water than by any other method. So probably introducing it somewhere in the childhood is probably the most important. I would start with the childhood and then we have our own data which says that most of the adults, by the time they reach 40, 45, they hardly, most of our data doesn't seem to say that beyond that age group, it is typhoid is prevalent. So maybe that age group of adolescent to that active reproductive age group, or 40 to 45 years, that is where the typhoid vaccine is most useful, is what I see from my practice.
Ashwini, what do you think?
No, I completely agree with Vidya. Having said that, I do see patients from periphery also, and culture proven typhoid is there in the periphery also. I don't know the exact burden because we don't have demographic data, and we don't have any center which is collecting that data. So it's very difficult to say it's related to urban area or rural area. But then the burden is significantly higher, and the misuse is huge. Misuse of antibiotic for typhoid is huge. So implementing typhoid immunization, even for adults, yes, it is the need of our.
Maybe, we all work in big private hospital, and we are seeing less number of typhoid compared to the physicians working in peripheral hospital. Recently, I was going through the blood culture positivity result from a mid-size hospital in Kerala. And I was surprised to see the blood culture list: Salmonella, 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 then E. coli, Salmonella, Salmonella, Klebsiella. More Salmonella than E. coli and Klebsiella in the blood. But that's a mid-size in the city, in the town hospital, not like metropolitan cities or a big hospital that we work. So of course it's a huge problem in the country.
Can I add
Jacob Johnson?
Yeah.
Yes.
Typhoid fever or salmonella typhi infection fever in children below 5 years is not like typhoid fever in the adults. Okay, so we need to, if you look at blood cultures, you will see that there's a lot of typhoid or salmonella typhi infection in below 5. So if you want to, and they are manufacturing salmonella typhi and putting those into the environment, and whether you believe it or not, typhoid fever is occasionally passed through the town water supply. Water supplies are contaminated with salmonella typhi. And so it's actually a man-made problem in many urban centers where the purification of water by sand filtration plus chlorination is not done well, and we don't have the coliform monitoring system in the absence of a public health superstructure, public health division in the Ministry of Health or in the government. So what we see is the tip of the iceberg. What we diagnose as typhoid fever is the tip of the iceberg. If you go to Thailand, you can eat on the roadside boldly, because we know that the food handlers are vaccinated with both typhoid vaccine and hepatitis A vaccine. In India, such a rule doesn't exist. So food handlers can have hepatitis A spreading around, or salmonella typhi spreading around, and since we don't have a monitoring system, somebody can go to a restaurant and get salmonella typhi, and nobody is checking how many other people who had gone to that restaurant have salmonella typhi. There is no system. So we do need a system, and I think medical people should argue for public health. Public health people are not arguing for public health.
David.
I think we shouldn't forget also that it's very difficult to diagnose typhoid. And so we don't have really good figures from laboratories on this, especially in peripheral areas. And so along with vaccines, we need to also be promoting in the antimicrobial resistance area point of care diagnostic tests, because those can simplify treatment, they can decrease antibiotic use, and they can also help us convince our policymakers that these diseases like typhoid are a problem.
right.
Over.
David needs to leave earlier, so I will ask more questions to David first before David leaves. And what's the importance of vaccinating animals? Because we have to follow the One Health approach in reducing or tackling the antimicrobial resistance.
Yeah, well, I was just preparing this morning a lecture on MERS coronavirus. And you know, MERS comes from camels into humans, and then it passes from human to human, mainly nosocomial transmission and occasionally close family contacts. But the emergence of this continues, and it continues because camels are carrying the virus in their nasal passages. And so what's needed is not a human vaccine because we don't know how to target properly. We need an animal vaccine, a camel vaccine that prevents camels from getting infected, and they're likely get infected from bats. So there are many, many things that we need to do, or at least think outside the box. Think about plague, for example. Just as an example, I'll go back to rabies first, because rabies has been eliminated in Western Europe by vaccinating foxes. Foxes carry rabies. They're vaccinated because there's a vaccine that's put on meat bait. That bait is put into forests. The foxes eat that bait and they become protected against rabies, and that protects humans against rabies. Plague is a disease carried by rats. What if there were baited vaccines for plague in communities? Could they decrease by vaccinating rats plague risks to humans? It's not clear, but these are things that need to be studied moving forward in vaccines, in viral vaccines, because again, plague is something that needs to be treated it's a bacteria, sorry, but it needs to be treated by antibiotics. So we just need to figure out ways of working better in One Health. And by so doing, we can prevent both viral and bacterial infections. Over.
David, I'll ask you the one more question because you've got extensive policy making experience. What policy changes or funding initiatives are necessary to accelerate the development and distribution of vaccines to reduce antimicrobial resistance as a secondary effect could be?
So what policies are required? I think India
What policy
already
changes are necessary and funding initiatives are needed?
Okay, well, first of all, I would say that India has become one of the world's major vaccine producers. And so government must have some policies right, because this is encouraging the development, the production at least, of new vaccines and the licensing. So that's important that there be policies. But India has brain power, which is not being used to develop new vaccines. And so the government should be encouraging also development of new vaccines within India itself for the diseases that are important in India. So policy changes in that respect could in fact increase the vaccine availability, the types of vaccines we have, and decrease antimicrobial resistance. On the other side, promotion of vaccination within India using locally produced vaccines is extremely important, and government needs to look where the gaps are. We all know the story of smallpox when Bihar and UP had such difficult time in gaining coverage, and the same for polio, in gaining coverage of vaccines. But eventually government policy changed or was implemented, and in fact, polio has been eliminated and eradicated from India. So policies are good, but many times the policies are not really enforced as they should be.
Right,
Over.
right. Thank you, David. Now, Jacob Jones, sir, the antibiotic usage in the veterinary practice is extensive in India and several other countries. We know that. We banned colistin growth promotional usage in 2019. And to my understanding, even though we haven't done a follow-up study, it's effective to a great extent because 85% of the colistin in animal is imported from China. And there's an import ban. So the importers are afraid of importing it from China because you lose your license. And nobody want to take that risk of losing a license just by importing an antibiotic for few hundred crores of business of the colistin antibiotic. But and some 10 to 15% are manufactured in India for veterinary usage. We don't know what's happening to that. Still, colistin is available in some areas. Limited usage still happens, but to my understanding, it's significantly less. It's good to do. I tried to collect some import data. Now it's after banning, the import data is officially not available. I do have the data pre-ban, but post-ban, there's no downloadable data in any of the websites, the government site or the business websites. And so what can we do to improve the vaccination coverage in animals, and definitely reducing antibiotic usage? As you know, recently I was writing to the Kerala government who banned the over-the-counter sale of antibiotic. Then I wrote to them, it's a good move, but majority of the food that is imported into used in Kerala is imported from the neighboring states where antibiotics are extensively used in agriculture and the poultry farming. And we are all eating antibiotic resistant bacteria laden chicken and vegetable day and night. So what can we do? What can we do? Can we improve the vaccination coverage to reduce the antimicrobial resistant and drug resistant bacteria in vegetables and poultry?
Is it an open question?
Yes.
How do they manage in other countries? So for example, if there is a E. coli causing the renal syndrome, one case in the state of Philadelphia, that will be picked up. And then CDC will see whether anybody else has that. And then they do a molecular analysis and see. So even one case will be picked up. Whereas here, hundreds of thousands of cases can occur, it will not be picked up. What's the difference? They have a public health survey. Federal government has it, a CDC run, and every state government has it. Every county has a county health officer. And these health people don't treat patients. They are public health people, and diagnostics is the most important thing. When you have an illness, it has to be diagnosed. The etiology has to be diagnosed. By our district hospitals don't even have microbiology department. A district hospital catering to the needs of 1 to 2 million population does not have a microbiology service that is available for blood culture or any bacterial culture. They have to outsource it. So we must clean up our own house. And once you have it, any antimicrobial resistance will then be looked at as to where does it come from? Where did it come from? Animal source, human source. Okay, so without that kind of respect given to data, I don't think we will move forward with AMR surveillance.
Right. So as per what Jacob Jones sir is stressing, that AMR surveillance is not just the surveillance or measurement of resistant bacteria alone. We need to have a detailed surveillance system data available on the prevalence of infectious diseases in the country. Is that, sir?
That's correct.
Right.
Say,
David?
when you buy food from a food store, packaged in Haryana, and somebody gets something, botulism, in one town in South India, do you know whether such things have happened in other places? Is there the whole food chain contaminated? We do not know that. So that's what I mean by a system that looks at all happenings and connect all the dots. Thank you. Back to David.
Yeah, I would just add to Jacob, with whom I agree, Jacob, I agree fully. We need to be also sure that the laboratories are linked to that surveillance system. And you talked about the importance of public health laboratories in each district or even lower. And it really is important that two things happen. They link to the surveillance system, but they also analyze the data locally and don't just send it on and forget about it. Because analyzing it locally can cause the advocacy necessary to get the government interested. Over.
Thank you, David. And audience, please write your questions in the comment box so that the panelists, expert panelists can answer your doubts, queries, and opinion. Vidya, please add to the comments to David and Jacob John, sir.
This was regarding. So sorry, can you please come around? Like this was about.
It's an open question, and any of the points you can make your comments and opinion.
Okay. So no, I think this is what I was also trying to tell earlier, that having some data on the disease burden itself. So I think most of the times that is what is missing when we talk about the simplest thing that happens that we really don't have access to in India. So we were talking about typhoid, as Dr. David was rightly pointing out, having some cheap diagnostics. It not only helps you to assess the disease burden, it also helps you to prevent antimicrobial use in the first instance at the point of care itself. So those kind of simple things is what I think we really need to invest in before we think of bigger things like, I don't know what Dr. Jacob John sounds really nice to have something like a CDC or a mini CDC or something like that, which is applicable to India, but simpler strategies like having low-cost diagnostics, universally accessible diagnostics, maybe standard treatment policies or guidelines by which we can restrict antimicrobial use and also advocate for vaccine policy is what are simple strategies that I think can be done.
Right. Both these strategies are very complex because having such a very, very sophisticated CDC system and also implementing low-cost diagnostic in a big country like India, both are very, very complex and complicated challenges.
With what Dr. David says, India has the brain power, India has in-house manufacturing capacity. I think we just have to put our focus on the areas that we really want to make a change on. And I completely agree with Dr. Jacob that we have to advocate for this. Nobody else is going to advocate for this.
Right. Innovation. That's a very good point. Innovation is what is my current passion. I talk a lot about innovation, startups, medics becoming innovators. You came to the right point. We have the brain, we have the ability, we have the technology. Only thing we need to come forward and develop the technology and deploy the technology. Ashwini.
So, like we have this Kerala action plan, what we need that could happen basically because of a strong political willpower. So that is also required in other states to implement it. And like everyone is saying, metrics are really important. We don't have a surveillance system, and what everyone is discussing, I feel it's a far-fetched dream for India to happen. But if we have a system in place, if we have a political willpower, probably with the brain and the amount of talent India has, we can achieve it in a decade's time. But then everything should fall in place, which looks a bit difficult to happen.
Yeah, but all politicians in the country have got the willpower. Only thing the public should ask for it. Politicians always give what the public demand. Jacobson, sir?
I will just pick one point. When we say low-cost diagnostics, low cost but quality, that when you get a result, that should be reliable. When I was working in Kerala, I took one blood sample from a healthy person and divided into two labs, saying suspected typhoid fever, the other lab suspected leptospirosis. Lo and behold, answer came back from both labs having confirmed typhoid fever and leptospirosis, one blood sample. So quality is very, very important. Indian Association of Medical Microbiologists runs a external quality assurance program, EQAS, for bacteriology based in CMC Vellore, for virology also based in CMC Vellore, and for bacteriology there is a unit in Gangaram Hospital in Delhi under the IAMM. There are two streams. North Indian labs are catered for from Delhi, and South Indian labs are catered for from CMC Vellore. So any lab can join. The expense is very minimal, and you get every month a blinded set of samples that you make your diagnosis, inform the central lab. You have a code number. Nobody else will know what you reported, and the central lab will assess your performance and guide you where you might have gone wrong and settle it right. So they have a incentive to improve their performance as time goes on. So external quality assurance is very important. And of course, you have to build an internal quality management system in every laboratory. So when you say low cost, commercial kits are available, but somebody should keep a tab on its quality all the time.
Thank you, sir.
Just had
Right.
one thing, sir. Like India, we have had pneumococcal vaccine for so long, like at least for at least a decade now, if I'm not wrong. Now, has it really translated into reduction in antibiotic use, or has it had some impact on antimicrobial resistance, like how the CDC claims that when the PCV7 or the PCV13 was introduced, they showed a steady decline in the AMR, the penicillin resistance rates. So that we don't know. I mean, so my own personal opinion is it's not just introducing vaccines which is going to make a change in the antimicrobial usage or in the antimicrobial resistance rates in India. We don't have data for that right now, so probably we should start tracking. That's why maybe having some low cost and probably quality diagnostics should also be something that we should be looking in parallelly to bring about that change in the expected change that we are looking forward to.
Even though we had pneumococcal vaccine available in the country over the last 1 decade, we introduced it in the national program, the pediatric program, only last year. That itself is not completely, sir, I don't think it's not introduced in all the states. It's being introduced step by step in all this. It will be introduced. We already started implementation last year. And of course, we know that in adult practice, not even 1% of the eligible population is receiving neither pneumococcal vaccine or flu vaccine. So, it's maybe too early to measure the impact of this vaccination on the AMR level from these two vaccines. And the flu vaccine, we know that it's not in the pediatric program, and adult also, again, not even 1% is vaccinated.
But the Indian Academy of Pediatrics have been advocating these vaccines for quite some time. And I know there is going to be a divide. There's always going to be a huge, say, a public sector, private sector divide. But then there is some population which have received the vaccine for quite some time. So there will be some measurable data in that sector, I think. So.
Right. And what about the new vaccines that are not available in India? As I discussed earlier, whenever I meet Vidya Krishna, I used to discuss, RSV is your pediatric disease. Why are you talking about RSV vaccine? Why do we need this expensive RSV vaccine? I changed my mind because I treat a lot of RSV in my oncology population. Now I've seen RSV people dying because of RSV, and because we do more RSV testing now. We do more of RSV, flu, COVID, people, affordable diagnostic test is available now. I detect more flu, definitely detecting more RSV. And definitely I'm looking forward for RSV vaccine because I'm sad to see so many of oncology patients are infected with RSV from the community. David, what do you think about RSV vaccine?
Like all other vaccines, they're very important because they prevent infection and they prevent illness and death. In the UK, for example, there's right now a campaign to give it to people over, I think, over 60, 65, because it's a common winter infection in the north. And this will prevent hospitalizations, and it will prevent the risk of picking up a hospital-resistant infection, and it will keep people at home where they're better off. So I think these vaccines are very important. And again, as you all know, in the UK, they only add an intervention to the public health or the clinical practices if indeed they're shown to be cost beneficial by an agency called the National NICE, NICE, National, I don't remember what the
Institute of Clinical Excellence, National Institute of
Yes,
Clinical
that's it.
Excellence.
Yeah. And so HITAP in Thailand is the same. They look at these vaccines and they determine whether or not in Thailand they will be useful. So India should be doing the same thing, maybe at the state level, maybe at the central level. I'm sure that the insurance companies are doing it. I'm sure that Apollo Healthcare and others are doing it in order to understand how they can make sure that they have the right programs for their people who are paying them. So I think it's very important that the government get on board. I don't know, is there a high top agency type in or a nice agency in India?
Jacob Jones, sir.
There is something called National Center for Disease Prevention. It used to be NICD, National Institute of Communicable Diseases. They had investigated 2 diseases for about 30 years. The Saharanpur encephalitis, which turned out to be a plant poison, Cassia occidentalis poison. In Bihar, it happened to be a lychee-associated hypoglycemic encephalopathy. And so NICD doesn't have either the depth or the breadth to function as a CDC-like organization in India.
Thank you, sir. And thank you for mentioning that lychee encephalitis. In fact, I'm writing a book called Outbreak Chronicles as a fictional stories. And one of the stories, in fact, the first story is the lychee encephalitis. And I would like to say that you're one of the major characters. Of course, it doesn't have your name, how you investigated and found out the lychee encephalitis. It's all like a fiction. But it's going to be, I think it's a very interesting story. I'm writing the last chapter of the Chronicles. I'll publish it soon.
Make sure it is accurate. So
that's
so,
why I said it's fictional.
yeah. Okay.
Right. Now, our favorite topic, the therapeutic vaccines. You know, every day when I see E. coli bacteremia, Klebsiella, Pseudomonas, Acinetobacter in intensive care units and oncology patients, I always wonder, what I need is a vaccine for this E. coli, preventing E. coli, clearing E. coli, Klebsiella, Pseudomonas, Acinetobacter. What's the role of therapeutic vaccines? And where are we now for therapeutic vaccines? Anybody can start. David.
Thanks, Abdul. I'll start and then I'll have to leave after this intervention. But, you know, therapeutic vaccines, in my view, were really not really recognized until COVID-19. And then all of a sudden, people understood that vaccines are not always vaccines that prevent, they don't always prevent infection. In some instances, they attenuate the infection. But we knew that from other vaccines in the past, but people really didn't put it together in their minds. And so if you ask a flu virologist today, does the influenza vaccine prevent infection or prevent serious illness? They cannot tell you. They don't know. So we've got vaccines that are likely therapeutic and not preventive, and they're very important because they decrease hospitalizations and they decrease, again, that risk of getting a hospital infection or a super infection. So therapeutic vaccines are extremely important in preventing disease especially in the elderly, where the disease and those with comorbidities, because they can't fight off these infections as well as others. But others will certainly have a view on that as well. And I'll listen to those, and then after I hear what others have to say on this topic, I'll leave the conference. Abdul, and thank you for having invited me.
Thank you, David. Sir?
You know, the concept of therapeutic vaccines has its origin in chronic viral infections, hepatitis B, hepatitis C, HIV, those kind of things, so that a vaccine that would herpes simplex, recurrent herpes. So that will direct the immune system to tackle and get rid of the problem. That is the philosophy behind therapeutic vaccine. Your dream of having vaccines for ongoing bacterial infections will remain as a dream for a long time. Have you read the book The Perfect Predator by Stephanie David? You know that book. Her husband had Acinetobacter baumannii in the brain, and ultimately they managed to get a cocktail of bacteriophages
Pages.
and then treated, and he survived and came out of his disease, and he got anyway. So she wrote a book, The Perfect Predator. So one way is enlarging our bacteriophage repertoire. Okay, so bacteriophage, that's becoming more popular. In United States, for RSV in children, you know what they give? Monoclonal antibody. The adult pre-F protein vaccine is not yet licensed in children. So that's, as David said, given for people above 65, whereas for infants they give the monoclonal antibody base. So that approach, monoclonal antibody based approach, is another way going forward. The third is cancer immunology, cancer vaccination, where you train your own cells to turn against the cells that have already become cancer. The mRNA vaccine for COVID actually came out of that thinking in terms of making the body manufacture the antigen itself and then respond to it with immune. Anyway, so your desire to have a armamentarium of treatment of severe infectious diseases that are antimicrobially not responding will remain as a dream for a very long time. But bacteriophage will probably come up as a realistic approach. Monoclonal antibodies will come up as a realistic approach, so that using the immune response system against infectious agents, but not inducing that through standard vaccines, but inducing them through very indirect means, it's very, very likely it will probably come into fruition in the next 5 to 10 years, I'm sure.
Thank you, sir, for giving a very good introduction of the concept of therapeutic vaccines. Just now, our event organizers messaged us that we got more than 100 plus attendees watching live from not just from India, from UK, Japan, Russia, Philippines, Saudi Arabia, Korea, Nepal, and a lot of African countries. That's nice. So many people are listening. That's the importance of how important the topic is, the vaccination in tackling antimicrobial resistance. Now, Ashwini, the same topic, therapeutic vaccines.
So the way we are using BCG for bladder cancer, can we call it therapeutic vaccine? I feel probably that is one of the way we can use it for a therapeutic vaccine. But I was recently reading about TB vaccine for this. So, but the TB vaccine which has been tried recently, which is in phase 3 trial, that also they have tried in 2 ways. One is therapeutic way, but probably we don't have data yet to say that it works in that way. But yes, we would like to have a vaccine, especially for HIV, wherein curing HIV is a far-fetched dream. So having a therapeutic vaccine for HIV probably will help us. Whatever attempts so far have been made for that have failed. But HIV, HBV, these are the areas wherein we need a therapeutic vaccine which will work and which will cut down the duration of therapy or which can at least cure the disease.
Right. Vidya Krishna?
So one area where I think I would really like to have a therapeutic vaccine is when we see a lot of children as well as adults having recurrent UTI. The children with urological abnormalities with who come to us with recurrent urinary tract. I think antibiotics, high-end antibiotics, more of gram-negative antibiotics are used largely in this population where either it's child or it's an adult. So I think somebody, if they can look into it and try to get, I mean, we have had a lot of guidelines and newer approaches to prevent recurrent UTI, right from cranberry juice to many things. But having a vaccine in that area will be really wonderful, something that we should be looking forward to.
You know, for bladder cancer, BCG is a therapeutic vaccine.
Yes.
And
Yes.
it's been used since decades actually, and it works. Yeah.
Yeah. Yeah. One of my oncology friends use a lot of BCG vaccination for bladder cancer. And once in a while, I'll see that mycobacteria spreads too, and I give ATG. Yeah, BCG associated tuberculosis. But definitely it will be a game changer for our E. coli, Klebsiella, neutropenia patients to prevent invasive Klebsiella infection, E. coli infection, Pseudomonas, Acinetobacter. It will be a real game changer.
I think we need a FAJ approach in India, which I think has a great potential in treating very difficult bacterial infections in severely ill patients, because FAJ can do wonders.
Right, sir. As you know, some of our universities are doing research on phages. The our Varanasi university is doing research on phages. They're doing some phase 3 clinical trials. But most of the phages that's being used in India, probably a few hundred patients so far, are being imported from Georgia. They've got, as you know, they've got good quality phages. But as you know, we are still in the quite early stages of research for phage. I'm doing, David.
Yeah, no, I think phage is right, but I'd just like to come back also. Jacob talked about monoclonal antibody. And really another avenue of therapy is monoclonals. And this is going to be more and more important. And again, India could be playing a major role in that. The scientific knowledge in India is incredible. It's just that these things have to come together and you have to become the world's resource for new developments and innovations, because that's what India is about. And you've got to continue to advocate with the government to make it more easy for people to do those things. But monoclonal antibody is a solution for many, many infections in the future. Ebola, for example, in Africa is being cured with monoclonals. So just to emphasize what Jacob said earlier, that monoclonals, in addition to phage, are very important.
All right, David, very good point. As you rightly said, it's difficult for India to be the leader of tackling AMR by implementing all the policies. Such a large country, so many socioeconomic disparity, we can't implement strict antibiotic stewardship, strict infection control, sanitation issues in the community. But India can be the leader of tackling AMR through innovation, technology, ideas, new antibiotics, new vaccines, low-cost diagnostics. That's where India can be the real leader and helping not just the country, and helping the world. Jacob Jones, sir?
Yes, I agree with you. But
Any other important, yeah.
What
sir.
do we lack in India? There is something that we lack in India. Is it motivation or risk taking, avoiding risks, that you do it if you are guaranteed success? Otherwise, I don't do it. I don't know. There is some flaw in our psychological makeup, I think, so that we don't fully utilize the brain power that we have. People use our brain power only after they go to UK or USA. They exhibit their brain power. In India, we don't. There's some flaw. I don't know where the flaw is, but if that flaw can be corrected, India can be a world leader in pharmacotechnology, biotechnology, in information technology. We have already established a leadership. So we do need motivation or inspiration or guidance or something we need.
Right, sir. Probably, the best brains in the country go to medical schools. And once you go to medical schools, after graduating, we become practitioners and we stop using our brain. We stop being innovators. We don't become innovators. Our medical community, we are practitioners. We don't innovate. We don't have startups. We don't work on technology. The biotechnology engineers are making most of the innovations. And we doctors keep away from innovation.
So can I pitch in? So
Sure.
working with you, I have seen so many startups who are working on all these current problems, what we have, be it a fast therapy, be it a cheaper diagnostic. So what I feel is we do have brains working for it. We do have people who are ready to strive for these innovations. But probably what we lack is a framework which puts everything together and gets channelized to get a proper outcome. Like someone is working in other fields, someone is working in different fields, someone is working in Faj. So if we have a framework which puts them together, probably we will have a better outcome.
Right. Good point. Vidya?
No, I was just thinking like, just as a side note to what Dr. Jacob John was saying, I think Indians, we are very competitive. So I think somewhere we have not learned to be collaborative. That's what I think. So from our schooling times, we are taught to compete with each other and come forward. Somewhere when we are also taught to collaborate and network and bring it together, I think we are doing it right now. So the system is changing. So it hopefully will change soon.
Right. David?
I can't answer the problem in India. I don't know the problem, but I would agree with what
That's
Jacob
a
said.
diplomatic answer.
The skill is there, and the people who leave India and go to a place where there's a good environment for scientific research and funding perform better than most of the local people. Indians are incredibly innovative and scientifically capable, and it's to the government to make sure that that is accepted within India and promoted within India, because your export of brains to other countries is damaging to India, and it doesn't get us the goods we need, because they're developing goods for the industrial world and not the developing world.
Right. Perfect. Jacob John, sir?
What can I say? I had a very interesting, very productive, very happy professional life in the United States. In my early career. When I was packing up to come to India, my mentor chief asked me, "Why are you going back to India? What is it that you lack here?" I don't lack anything here. Good money, good recognition, appreciation by peers, students call you the best teacher, and so on. So I thought about it myself and said, if I want to get something, I go to United States. But if I want to give something, I come to India. Okay, so I looked at the public health in the United States, and I've been arguing for such a system in India for a long time. However, when I came back to CMC, the need was we had 24 hours microbiology, bacteriology, biochemistry. but no virology. So I'm a pediatrician. Okay. I took it upon myself to transform myself into a virologist, established the first diagnostic virology, and in late 70s, now in pediatrics, we have summer diarrhea, winter diarrhea. Respiratory infection more or less throughout the year, but a spurt in October, November, December. Okay, they're all bronchopneumonia. They get loads of antibiotics, macrolides, and So I set to investigate them, and the October, November, December bronchopneumonias all happen to be RSV bronchiolitis. So we stopped giving antibiotics if an infant has bronchiolitis, particularly in the months of October, November, December. So, I mean, I'm saying that, yes, if you want to contribute to society through medical expertise, India is a good place to provide. But as Vidya said, we don't network enough. We do not somehow develop a system in which we support each other. Is our talent appreciated by others? Is there a demand for talent or skill or successful brains? We are all equal. So there is something that, and of course, what are we interested in? Number one, politics. Number two, cinema. Number three, cricket. So our priorities are different. We do need cultural leaders who will look at our culture, philosophically look at our culture, and then try to find the fault lines, which I do not know. I'm not a philosopher. I'm not a good person to observe the system and find fault. I can only look at the medical scenario. So we do need cultural leaders so that they will give us some clue as to where we can, as a nation, rise up to the standard of brain power that God has given us. We are not using that.
Right, sir. That's perfect. And thank you for, telling us the history that is in the 1970s when you came back from US and established the virology time. That's a time when I was born, and that's a time Vidya Krishna and Ashwini Taide were nowhere in this world. But it's important for us to know such important milestones in the science in our country.
Probably we need more champions like Jacob Johnson.
Clone me. No,
Right.
that will not work. Actually, the system is not right. I personally have had lots of obstructions that I have to live through, and instead of confronting the obstruction, I go around it. Okay, keeping the integrity intact, there are ways of weighting it and solving problems. However, Nichi, for example, or the Cassia occidentalis, for example. But how many people follow me in solving problems? Okay. In both places, I was called because I'm a virologist. Come and sort out this virological disease. And in both places, it had become a phytotoxic problem, plant problem. And because they come in clusters, they look like epidemics. They are epidemics, but the mindset is all epidemics are infectious. And if you don't know what infection, viruses. So that kind of simplistic understanding is right from top level health people to small hospital, the same mindset works.
Right, right, right. David?
I have nothing to add. I think you have a good philosopher sitting with you in Jacob. I've known him for many, many, many years, and I respect his knowledge and his ability to really move forward. And I think his advice is very sound. So, Jacob, instead of bypassing those challenges now in the future, hit them head on and solve them.
The two ways of approaching challenges, hitting them head on or bypassing. So, what we learn based on the circumstances, we need to follow both approaches.
That's right. My view.
Okay, Kafur, you want to
Right.
ask people have any questions from the audience?
Any questions from the audience? We haven't got any other questions.
Okay, I think it's then time to.
Yes. Thank you, David. Thank you, Jacob Johnson. Thank you, Ashwini. Thank you, Vidya. And thank you, the attendees and it's a wonderful discussion. We discussed about vaccines, AMR, philosophy, innovation, policy, politics. We discussed about everything under the sun in 1.5 hours. And again, may I express our thanks to the CIPLA, Milan and Pfizer for giving us unrestricted educational grant, small grant, so that we don't have to charge the attendees for the webinars. And because AMR Declaration Trust has very, very limited resources. But still we are conducting webinars, almost 1 or 2 webinars a month. We bring out booklets and we do other educational activities. We plan to do more such activities in the future. Thank you all. Thank you very much and good night.
Good night.
Okay, good night.